the CREST study is a phase 3 study in BCG-naïve high-risk patients. This was a randomized study and comprised of patients of which were a cohort of over 1,000, which is quite phenomenal for us to see in our non-muscle invasive bladder cancer disease state. And patients were randomized to either being treated with BCG induction plus 2 years of maintenance plus Suzanne, which is a subcutaneous formulation of an immune checkpoint inhibitor given every 4 weeks for 2 years. So that was one arm called Arm A. There was also an Arm B, which Suzanne was given with BCG induction only, so no maintenance. And a third arm, Arm C, which was the standard of care, BCG induction plus maintenance. This study was also impressive in its degree of follow-up. There was a median follow-up of these patients of 36.3 months. So lots of long-term data to understand what's happening. The primary endpoint that the trial looked at was a term called event-free survival. And that comprised of a couple of different endpoints. One was recurrence of high-grade disease, progression of disease, so as to muscle invasive or node positive, persistence of CIS, and then, of course, death from any cause. And what the trial found was that in Arm A, okay, the Suzanne plus BCG induction and maintenance, okay, there was an event-free survival of 82.1% at 36 months versus standard of care, BCG induction plus maintenance, 74.8% event-free survival. And so this is a difference of about 7.3% in which use or addition of an immune checkpoint inhibitor added. All right. Now, there was no significant difference between that, what we call Arm B, where we gave the immune checkpoint inhibitor just plus BCG induction, okay, versus BCG induction plus maintenance. All right, emphasizing that the use of maintenance was very important to seeing these impressive results or creating longer event-free survival. Now, when you looked at, again, those patients that had an event, okay, in the group that had the immune checkpoint inhibitor, Suzanne, they had approximately a 17.3% or 61 events, whereas the standard of care had 24.4% events, or a total of 89 patients had that. So a difference of only 8%. But when you broke it down as to what events happened, I think is very enlightening. That really we found that the biggest difference between the groups was in the rates of recurrent high-grade disease. So in those patients that were in Arm A, the arm that gave that immune checkpoint inhibitor, they realized a 50% less, okay, recurrence rate of high-grade disease than patients who had the standard of care, BCG induction plus maintenance. So it's a 7.4% rate of recurrence of high-grade disease when receiving the immune checkpoint inhibitor versus a 15.1% in BCG induction plus maintenance. We didn't really see much of a difference in the endpoint of progression. So again, that this event-free survival, okay, primary endpoint comprised of a number of different endpoints, okay? One of which was the recurrence rate of high-grade disease, which we just talked about. The other one was progression of disease. So that was similar between the groups. There was also similar in regards changes in stage of progression in non-muscle invasive disease. So similar in progression to muscle invasive disease, similar in changes of stage of progression in non-muscle invasive disease. So I think this is very enlightening to break it down this way, to really understand what was the driving force in the difference between the two groups, because this combined endpoint of event-free survival really comprises of a lot of different things, all of which are important. But it really comes down to helping us understand how are we going to use this data when we're talking to patients. Because certainly what this trial shows us is that the needle is not moving very much, okay, when we add a immune checkpoint inhibitor, if we're talking about progression of disease. Is adding an immune checkpoint inhibitor stopping the progression to muscle invasive disease? Well, at least right now where we are, okay, at 36 months median follow-up, we're not seeing that. Okay, the two arms really had no difference in progression to muscle invasive disease. But what we are seeing is that there is a difference in the rate of recurrence of high-grade disease. So could adding an immune checkpoint inhibitor like Suzanne decrease the burden, okay, of non-muscle invasive disease? So could it decrease, again, the number of TURBTs that these patients are undergoing? Well, if you just look at that solitary endpoint, yes, it could. And so what's important to then weigh, okay, is, well, how burdensome is adding an immune checkpoint inhibitor, okay, to the treatment plan for these patients? Well, the immune-related adverse events, grade 3 or 4, ones that we definitely get concerned about, was about 15.7%. And the median duration of treatment of use of Suzanne was about 80 weeks. So what's needed to be balanced when interpreting these results is the risk-benefit ratio, okay? And what benefit is meaningful to our patients, to us as providers. So again, is a decrease in the recurrence of high-grade disease by 50% worth the risk of developing a grade 3 or grade 4 immune-related adverse event, which occurred in about 15.7% of patients? And that's what we're going to have to balance here. The other trial that is soon to be reading out, which is going to be very interesting to compare to, but which we only have a little hint of information is the POTOMAC trial. This is another phase 3 large trial in our BCG-naïve high-risk non-muscle invasive bladder cancer patient group. And it's where BCG induction plus 2 years of maintenance was given alongside a different immune checkpoint inhibitor called durvalumab. Durvalumab is IV immune checkpoint inhibitor, and it's given for 1 year, at least in this trial. And again, they had the 3 arms as well. They had just say arm B, if you will, which was the immune checkpoint inhibitor plus just BCG induction, which unfortunately did not meet the primary endpoint for them. And then the third arm, which is the standard of care BCG induction plus maintenance. Now, AstraZeneca, who kind of ran this trial, did deliver a press release in May of 2025 showing that the addition of durvalumab, again, an immune checkpoint inhibitor for 1 year to the standard of care BCG induction plus maintenance, resulted in a statistically significant and clinically meaningful improvement in their primary endpoint, which is called disease-free survival, compared to the standard of care alone. But beyond that, we don't have any hard data. The hard data is going to come out at ESMO this year, which will be in October. One interesting thing to note about POTOMAC is that this trial was international. There was no US participation. And so actually AstraZeneca again started up a really sister trial called PATAPSCO. And this was actually only US centers and really comprised very similar of the same trial layout and really had a large number of large urology group private practices participating, and really is a phase 3B where we're only looking at the safety data, again, using US sites. The patient population also appears to be a bit different than CREST. So something to kind of have in the back of our minds that I'm sure the readout in ESMO will address. But this study, POTOMAC, which is going to be read out in just a couple of months, really started 2 years prior to CREST, and was an international study, so it's based on EAU definitions, and was based on an EAU definition of high-risk disease, which was broader at the time of trial start. And so some of this intention to treat population will actually nowadays is going to be defined, a subset of that population is going to be defined as actually intermediate risk. So something, we'll have to look to see how that plays out. But one of the biggest things that I think we'll all be looking for at ESMO is, does durvalumab move the needle on progression of disease? Whereas in CREST with Suzanne, we didn't see that needle move very much from our standard of care. It did move the needle on the recurrence rate of high-grade disease, and so could offload the burden of disease treatments that our non-muscle invasive bladder cancer patients are experiencing currently with the standard of care. And then we'll also be looking at what is the side effect profile of durvalumab. Are we still seeing around 15 to 16% of immune-related grade 3, grade 4 events, or does it have a more safe profile? And then we're trying to better define also in both CREST, and we'll be looking at POTOMAC too, is there a clinical subgroup that such a intensification of first-line treatment is better for, where that risk-benefit ratio is going to fall more evenly, as there seems to be more benefit in this particular clinical subgroup, such as CIS. The CREST trial definitely, when looking at their clinical subgroup analyses, are showing that there definitely does appear to be a higher benefit of adding an immune checkpoint inhibitor if patients had CIS, if patients had T1 disease versus the pure TA high-grade, high-risk non-muscle invasive bladder cancer patient.